Hey everyone, I'm going to be talking to you about the introduction to the Hamilton G5 ventilator coming to an ICU near you soon. The Hamilton G5 fleet is going to replace the Avias at OHSU within this fiscal year, and the Hamiltons are a very powerful ventilator, but there are a lot of differences compared to the Avia. So I'm going to go over some of these. First, let's start with the basics of the screen. Currently, we have this patient set on volume AC, which is SCMV mode in the Hamilton vent. What I want to point out, though, is the settings of the vent are along the right side, starting at the top where you can see the mode up here, and then as you go down, you can see what is set in this mode. This patient's on a rate of 18, a tidal volume of 500, a PEEP of 5, and on 21% oxygen. The rest of the screen is dedicated to what we're reading out from the vent. If you go to the left side of the screen, you can see that we're reading out the total respiratory rate of 19. The exhaled minute ventilation, or minute volume, is 9.1 liters per minute. Got an exhaled tidal volume of 490. You have this patient getting 6.8 mils per kilogram of ideal or predicted body weight. This is important as we go forward in trying to promote using lower tidal volume ventilation for our patients, lung protective strategies. And then you have the peak airway pressure. Underneath this, you can see this says 2 out of 9 screens. These are monitoring screens that have an enormous amount of data if you need to use it. The respiratory therapists are going to use this a lot. You may use certain parts of this. Right now, we're seeing the peak pressure, the plateau pressure, the mean airway pressure, how much PEEP is being measured, and the delta P, which is plateau minus the PEEP, or the driving pressure. If you go down a screen, if there were an auto PEEP measured, it would show up here. If we have an esophageal manometer, you would have a PTP, a transpulmonary pressure. You have an inspiratory flow rate and an expiratory flow rate as well. Inhaled tidal volume and exhaled tidal volume. This can be very helpful when you have a patient you think has an air leak. Again, your minute ventilation, your total respiratory rate, and their spontaneous respiratory rate. You have an I time, an E time, and an I to E ratio. This is also extremely important in a lot of patients, particularly with airflow obstruction. I'm going to scroll through a few more of these. This again is the mils per kg of predicted body weight. There's leak, got a lot of other things. For the most part, I don't think you're going to be using a lot of these. Otherwise on the screen, what you can see is that we have across the top the pressure waveform, pressure over time, and then the flow over time right underneath it. Just as you're used to seeing on the Avias, the pressure is on top, the flow is in the middle. I'm going to pause the screen for a moment by pressing this button here. Now the screen is paused. Hope you can see that there is a little tiny pink triangle right here. That pink triangle underneath this breath says that the ventilator is sensing the patient triggering that breath. That is a patient-triggered breath as opposed to these other breaths here, which are not. This one. There's another way to tell if a patient's triggering a breath. If you look down here, this is the dynamic lung. That down here, that's the diaphragm. That is the ventilator detecting diaphragmatic movement. So every time on this dynamic lung, you see that flashing diaphragm here. That is the ventilator detecting a patient trigger. So there's 2 ways on this ventilator to tell if a patient's triggering a breath. One is this little pink triangle underneath each breath. The other one is the presence of a very short, I admit, diaphragm underneath this dynamic lung. What I'm hoping to show you, though, is from the doorway, you can probably detect if your patient is breathing on their own spontaneously. So, as I said, there's a pressure waveform, a flow waveform, and the dynamic lung. The dynamic lung is something that is specific to the Hamilton ventilators, and what it's meant to do is visually show you about the patient's compliance as well as their airway resistance. On each ventilator, there is a laminated sheet that goes over what the different pictures are. The shape of the lungs on the outside tell us about the compliance of the respiratory system, and the color of the airways themselves in the middle are going to tell us about resistance. Well, what would happen if this patient were to have increased airway resistance, let's say an asthma flare, bronchospasm? So let's give him some bronchospasm, and we'll see what happens over time. So let's see, over time. You can see already that The peak airway pressures have gone up significantly, as you would expect for a patient with increased airway resistance, and the ventilator just changed its scale to show you. But did you see these airways have turned red? That is a visual, so you can tell that the resistance has gone up significantly. The more red these are, the higher the airway resistance. So let's say we've given this patient some bronchodilators and we've suctioned them, and now their airway resistance goes back to normal. Okay? The first thing we see is that the airway pressures have gone down significantly, and the inspiratory resistance that's being measured went from 140 something down to 5. And this iterates over several breaths, so it's going to take a while to go back to normal. We'll give them a few more breaths, and we'll see that red airway tree should go back to the sort of neutral color right now. There we go. If you wanted to set it up the same way we've usually been seeing our waveforms, you can go to the graphics button here, and you can actually choose layout number 1. Layout number 1 should seem very familiar to everybody. It's the way we've been showing our waveforms on the Avia over time. We got the pressure waveform on the top, the flow waveform in the middle, and the volume waveform underneath. You can also add another one underneath for esophageal pressure if you have an esophageal balloon. And eventually we're going to have volumetric capnography, which will also show there. So you can see these in real time.